everyone. I'm Dr. Meshari Bugami, and I'll be presenting today severe aortic stenosis surgery versus percutaneous intervention. The case is about a 75-year-old non-diabetic hypertensive who was admitted through the ED with a decreasing symptoms of shortness of breath and breathing syncope. He had previously been diagnosed with severe multivessel disease and AVR CABG, but he chose to leave against medical advice and he came to our center. Investigation, the blood works were unremarkable apart from an A1C of 10.1. Kidney function was normal, other labs were unremarkable. Echo showed an ejection fraction of 55, heavily calcified degenerative valve function as bicuspid, mean gradient of 30, maximum pressure gradient of 56 millimercury, and diminution index DVI of 0.22. Aortic valve area was 0.9, and the LVOT diameter was 2.2 centimeters. This was his diagnostic angio, which is showing a mild distal RCA disease. In the left system, as you can see, there is significant distal left main involving proximal LAD with ostial circ haziness. So now we come to the decision in the heart team. Is it surgery or percutaneous? Who should be treated first? Is it the coronary or the valve? And MCS support, is it needed or not?
Thank you, Meshari. So we'll have a stop here and go around the table with everyone. So I will start with Dr. Anas Merdad. So you've seen the case and everything. What is your thought about the case? He's a 75, came with the symptomatic class 3 symptoms, severe aortic stenosis with an EF of preserved ejection fraction and distal left main. So what's your thoughts?
I guess the most important things to look at to hopefully guide, what strategy to go for this patient from an echo standpoint is LVEF. This importantly, does help stratify the risk of the patient. The presence of extreme hypertrophy and the LV cavity size, potentially for that, risk of suicide LV post, TAVI. The risk of RV, to check the RV function, potentially to guide, for example, mechanical support, which may be potentially needed if the patient goes for a transcatheter approach for the coronary, whether before and after the valve. For example, if someone has RV failure, ECMO does provide RV support, whereas Impella may not do that. So these are the main things that I would look at in the context of severe aortic stenosis and distal left main disease to help inform the risk of the patient.
So we have a surgeon and interventionist on my left side. So what are your thoughts, Dr. Raed? I mean, you gave us a talk yesterday about robotic surgeries and minimal invasive surgeries. If this patient was presented to you, what are your thoughts? What are you going to tell us?
I mean, he's an EF is 55 and he's like 75. I think it depends. If he's not a high risk, I will just take him for CABG AVR. I think that's probably, in my opinion, probably the best approach. Now, if you want to talk about minimally invasive, a lot of those, sometimes they do want to, either they're frail or they do want to go for the sternotomy. So I think we've done few cases, actually quite a few cases where we do hybrid LIMA, robotic mid-cab or LIMA to LAD, and then you have a protected LIMA so you can stent the circ, and then you go for TAVI after.
Okay. What about Dr. Nicole? You've been asked yesterday specifically about the age in TAVR, and you gave us a good talk. So 75 this time. What are you going to do with this patient? He's in Lebanon with you, and what is your thoughts?
So I guess the age per se is just a detail, I would say. We need to look at the entire picture of the patient. It's very difficult. I mean, we should see the patient first. If he's 75 and looking like an 85 is this thing, and 75 very active is different. We have several arguments to go for one or the other. One thing is that he has a normal LVAF. He's 75. He has a good, most likely, quality of life. What I'm worried about is a bit the bicuspid valve and the small LVOT, I would say, because it looks like a 22. I don't know what's the size of the valve. So I guess at this point, if you want to really go ahead and decide on what to do, we need to look at the CT and put the entire picture
All
together.
pictures together. So, Dr. Ali, what is your thought? I mean, now we heard from a surgeon, interventionist, and the imager. We said putting it all together, providing that the CT looks good and the peripherals are good and the sinuses are good. So he's suitable, let's say, for 26 balloon expandable valve. Now you heard from both. How is your target? What are you going to go? Are you going to go for percutaneous? Is it like 50-50 now? From your right and your left?
So I
You
think
will
this,
tip the scale.
so, typically those patients will go into the heart team rounds in our center, and we have the surgeon involved in our discussions as well. It's not uncommon for those patients to refuse surgery. At the end of the day, the patient is 75, and I think looking at, it's a complex anatomy, but I think it's very doable percutaneously. The main question would be the approach to treat those patients. Are you going to fix the valve first with TAVI, or are you going to fix the arteries first? And I think this is an evidence-free zone. The complete TAVR trial being conducted in Vancouver is addressing this question, and I think it will inform practice a lot. But if you ask 10 different interventionists, they would do different things. In my practice, we tend to fix the valve first because I think, we think this gives a more hemodynamic support when you fix the arteries. You really don't want to go into a dissection or no reflow phenomena in a patient with severe aortic stenosis collapsing on the table. This is very unfortunate situation. So, I think fixing the valve with a TAVI first is reasonable, followed by PCI to the distal circ back to the left main, probably a staged procedure.
In a stage matter. So finally, Dr. Haji. So 50-50, going for PCI and percutaneous option. Of course, going to go with percutaneous option. So 2 percutaneous and 50-50. We talked about mechanical support, and you have some good experience with structural in a shock status. What kind of mechanical support, providing that if you want to go for percutaneous option?
Yeah, I think first of all, those kind of patients, we have a lot of registry data on coronary artery disease patients with aortic stenosis, but those patients were not studied. Left main patients with valvular stenosis not well studied. And I think looking at the anatomy, the patient has calcified nodules, so you will need to perform a lot of modification before you proceed with stenting. So you anticipate a lot of ischemia. So I think in this case, I would go with mechanical support.
Mechanical support.
And the choice here is I prefer Impella CP in this case. I would fix actually the coronary. I know that most of the time we fix the valve first and then we fix the coronary. But looking at the images and the flow in the left main, I think this patient is suffering a lot from ischemia from the coronary. And looking at the hemodynamics of the aortic valve, gradient of 30, aortic valve area of 0.9, I would do both at the same setting. I will fix the coronary as well at the same setting.
So coronary valve with Impella support.
Yeah.
What about you, Ali?
So I just want to add another comment here. I think the presentation is very crucial in terms of what to fix first. So if the presentation is predominantly ACS with NSTEMI, ACS, or STEMI, I would agree that maybe fixing the arteries first would be the way to go. The other consideration for you to fix the arteries first, I guess, the use of mechanical circulatory support, especially if you want to use an Impella, because we don't really like to pass an Impella into a fresh transcatheter valve. Now, if you're going to put an Impella in severe aortic stenosis, there are different approaches, but one is to balloon the valve, put the Impella, but should be ready to put a valve in case you have severe regurgitation after balloon valvuloplasty. Or you can actually, there has been some case reports to put an Impella into a severe aortic stenosis patients successfully. And we've done that in practice in very selected population.
Dr. Nicole, any experience when it comes to mechanical with the TAVR cases? Like, what is the preference of choice?
The preference, honestly, is to go rather for a more serious ECLS assist. We've done it, I was working in France before, so we've done it as a standby procedure, having all the material ready and in the room in case we need it. In one or two cases, we really implanted at the beginning and then did the procedure, but most of the time, just keep them on standby and be ready to switch if needed.
Final question, Dr. Raed. If I called you in the cath lab and told you, I have this case, we presented it, most of the table we're talking percutaneously, we need your support. What kind of support you're going to offer me? Standby surgery or standby mechanical circulatory support or put the ECMO? What is your thought?
I think both. I mean, if we're gonna go for percutaneous, then I would like to have the ECMO in the room. I think in our, I agree with everything you guys said. About trying to go with symptoms. If the patient is coming with STEMI, non-STEMI, or whatever, trying to treat which one first, PCI versus TAVR. But I have to tell you, as a center, we do about 700. We do probably. I would say probably 50 to 70 of those typical, the same anatomy, and every single time we actually question which one to do first, and we've been burned out multiple times. So I think the threshold of having a mechanical support, and we prefer ECMO. I think Impella and balloon pump, we didn't have a good result. I think ECMO was the basically actually we do have ECMO. And we have it in the room, and then the threshold of putting the patient on ECMO is really very, very low.
Do you intubate the patient and put him to sleep while putting ECMO, or the patient is awake, conscious ECMO?
All of our TAVRs are awake.
Awake. So we have lots of people in the room. So show of hands, who will go for the percutaneous option? Okay. Who will go with the surgical, of course, surgical option? Okay, who will put the mechanical circulatory support up front in this case if you're going to go with percutaneous? Oh, little. Okay, so take it away, Meshari. Show us what have been done. Can I have the slides back? Yes.
So here we started our procedure by assessing the peripheral.
So the decision was to go for percutaneous option?
Yes.
Okay.
And we assessed the suitability of the peripherals for access. As you can see, there is no significant peripheral artery disease. So we went ahead and we maintained our access decided to go with the mechanical support and for the TAVI. And then after that to go with the PCI. And we obtained our access for both the ECMO and the TAVI.
So in this case, I will take it from here, Meshari. We can see out of the back that the patient had an ECMO inserted for him, and the patient was awake. And this is one of the earliest or first cases that we had a conscious ECMO while doing TAVR. So we are doing now here, the implanter view. We put already our pacer. Next. We did the balloon. Also, you don't want any surprises during it. And you can see we have good accessibility and good inflated balloon. Next. This is Sapien 26 balloon expandable valve, which was deployed, I think, in 2080 deployment. Next. And here we can see the patient was really stable throughout the case while we're doing this. Next. So the question is, which one is first? In this case particularly, the decision was mechanical circulatory support, awake and conscious ECMO, do the valve, then the coronary in the same setting. Since there is an ECMO, we felt very comfortable that since there is an ECMO, maybe if there wasn't, maybe we'd have staged it. But in this case, the patient was very stable, so we proceeded with doing PCI to the left main LAD with the targeted provisional stenting. Next.
So the procedure now, after deploying the valve, we proceeded to do the BCI and fix the coronaries. It was a planned BCI to left main LAD using IVUS guided. Here, as you can see, we engage using a guide to the left system. Then we wire both the LAD and the circ.
In a second, Meshari, I'll just ask the interventionist. Keep the running. So, Mohammed, is there any Dr. Mohammed Haji, any preference in terms of the kind of the guide or the strategy that you're going to go from the coronary side?
Yeah, I guess first of all, I would use, as you mentioned, showing short frame valves, just to make sure that we have easy access to the coronaries. And I think if you use a short frame valve, you can do your coronary work as you used to. You don't need to downsize the coronary guide. But since it's left main, you want to have at least 7 French. You have 2 wires and proceed with intervention. As I mentioned, you probably will need to do a lot of calcium modification in this procedure. I'm not sure if you use IVL or. Yeah.
What is your preference of choice? You're going to go with rota, scoring, cutting, OPN, or
I
IVL?
I think with calcified nodule, you either want to do IVL or rota. I don't think the scoring will be enough for those kind of cases.
Okay.
So IVL is
So,
good.
Dr.
choice.
Anas, I mean, this is a setting. Do you think there should be an imager inside of the room, like either with a standby transthoracic echo or TEE?
I think it's, so what we usually do for TAVIs is we do transthoracic pre and post, even transthoracic on the table. We don't necessarily do TEE for TAVIs unless there is expected, very high risk for PVL, and we really want to be sure what the valve looks like after deployment. That's when we would use a TEE. But otherwise, I think a transthoracic should be enough unless, we're worried about something, yeah.
So, Dr. Wright, is it your time to leave the room as we're doing the coronary, or will you still stay in the room with us? Of course, you like this, but
It depends. I think most of the cardiac surgeons probably they leave, even in the U.S. But I mean, I have a special interest in all these structures, so I stay to the end of the
to
case.
the end of the case. So,
I recommend that to stay to the end of the case, specifically with this anatomy. I think this is
better to stay?
better to stay.
Ali, what do you think might go wrong at this stage? We don't want to celebrate very quick. Okay, the TAVI high five, coronaries. You think something might go wrong with, of course, Mohammed has already mentioned the lesion modifications. Any thoughts, like what should you anticipate? What should you have inside of the room?
So a lot of things can go wrong. This is a fresh transcatheter valve. It can embolize by pushing or pulling a lot into on the catheter. You can have embolization from the native calcific leaflets to the coronaries, causing coronary obstruction, not necessarily the leaflets mechanically obstructing the arteries. And this is a complex left main lesion, so that adds to the risk as well. I'm really glad you used a short frame transcatheter valve, because if you can notice, the left main height in this case is actually short. The forgiving feature here is the patient has capacious sinus. But I do believe that if you use the tall frame valve, you may have issues accessing the left main in this case.
Can you proceed, Meshari? So this is modification. What kind of modification that they have used in the case?
So we wired both the LED and the circ. We went ahead for the region preparation part. We ballooned both the proximal left main LED using 3520 non-compliant balloon and 3515 for the circ. Further lesion modification was needed, so we used also an IVL of 3512 with a good debulking for the distal left main black. After that, we stented, as you can see here, in a provisional technique, left main to LED, with the good result in the flow to the LED. And as you can see here, we adjusted our wiring back to the LED with a good result. So here we decided to further assess our stent. So we did IVUS. IVUS showed good stent expansion with no edge dissection or malposition. And by the end of the procedure, the whole procedure was done under conscious sedation, with the ECMO being successfully decannulated at the end of the case. It's actually one of our early cases as a conscious ECMO back in our center. The outcome of the follow-up, the patient had an eventful post-procedural course and reported symptomatic improvement in the outpatient follow-up. Repeated echo showed ejection fraction to be maintained at 55, with a good functional aortic valve with a mean gradient of 6 and no valvular leak.
So I'll stop you here before the conclusion you give us. So we've done, as in the case now, conscious ECMO, put the valve, do the intervention. Will you go more aggressive with the coronaries? You're going to go, for example, we had the bifurcation. Anyone from the interventionist will go for more functional assessment of the side branch, or just depend on your IVUS and the left main LED. What are your thoughts, Dr. Mohammed?
I usually don't if the flow is good and there's no significant pinching of the left circ. So I think I'm happy. I will be happy with the results. Of the intravascular ultrasound showed very good expansion at the ostium of the LAD bifurcation core and the left main. So I would not, do a lot of push for physiology here.
I totally agree. You went with a provisional, and I think you should stick to that. The flow is TIMI-3. We don't have a lot of impingement. I would just leave it the way it is, and then the patient has been symptomatic. We can monitor with that.
Dr. Ali, any thoughts?
I agree with the comments. I would just go with imaging guided in that case, and it looks like you guys had a great result.
So Dr. Raed, he mentioned about the decannulation in the OR or the hybrid. So is it the same practice you've been managing, like, decannulation on the spot? And what kind of, are you going to go with, proclose or percutaneous closure devices?
Yeah, I think, we will decannulate at the same time, percutaneous closure. We have a great team with Perclose or Manta. We all close them percutaneously. I think, but again, it's all about the comfort level. With the percutaneous, or you make an incision and just do a primary closure. The question or at least what I will do, a lot of these cases we're doing them in the cath lab. I don't know, for the surgeons, would you, first of all, this case was done in the hybrid room or in the cath?
Hybrid.
Hybrid room. What was the backup for the surgeon? Can he do the surgery if something wrong?
The surgeon was inside of the room, yeah.
But if the patient need to go for surgery, would he do it in the same room or?
Yeah, they have all the capacity.
That's, I think, the key, which actually we learned it. We have two systems, two hospitals in Henry Ford. One of them, we do the things in cath lab, and if something happens, we go to the OR, which is in a different floor, and the other one, we actually do it in the same room. Patients who were opened in the room survived. Patient who moved to the OR died.
To be honest, we had the same experience. Some of the patients that they needed, which is like, luckily a very small number, who was in the cath and moved in, or they even brought the surgeon to the cath lab, they didn't survive. Whereas the one in the hybrid, they had a better chance.
Time, I always say, like, the first 15 minutes of the patient is very important. If you don't have the surgeon in the room and the team that can open and go on bypass or do something, those patients don't survive. Luckily, with the advancement of TAVRs and the amount of times we convert is very, very minimal. But if something happens like this, if you need to open, time is money.
So with the closing in this, Dr. Anas, the case has been discharged. What is your recommendation about follow-up imaging in this case? And any thoughts about the pharmacological follow-up? Stent was put. You're going to go for a year, 2 years, and yeah.
Yeah, so what I would usually follow up on from an imaging standpoint is to make sure to look at the valve. Usually what we do is 1 month and then 1 year. After that, and then the annual or every 2 years thereafter. And what we usually look for is any evidence of PVL. It's very important that your echo lab is experienced to really map the valve and look at it from different angles to make sure that they don't miss any leaks. Obviously, from a pharmacological standpoint, your second question is, I usually put these patients on DAPT for a year, and then basically downgrade to aspirin.
What about you, Mohammed? Pharmacological management post?
Yeah, I think I'll put them on DAPT for a year and see if he can tolerate DAPT longer in the future, but at least DAPT for a year.
No, for a year. Dr. Nicole, should we consider this like, calcified, modified lesion, left main is like a high-risk intervention? So would you go for an extended DAPT or still we stick to 1 and then SAPT?
Here again, I have to go back to the age. He's 75. I don't know about all his comorbidity. If we can go beyond 1 year, I would like to. But we have to see how he's going to tolerate his DAPT for 1 year.
Ali, what is your thoughts?
Probably a year.
A year.
And then, I do worry about risk of bleeding in elderly population, and I think we're shifting towards more shortening DAPT duration. I know this is a high-risk anatomy, But, given we use intracoronary imaging, we made sure the stent is well expanded, there's good apposition. I would be comfortable with a year of DAPT and then single antiplatelet
For the
therapy
SAPT
thereafter.
afterward, you go for the now lots of talk coming, continuity of a SAPT with only Plavix or clopidogrel versus aspirin.
Yes.
What is your choice as a single antiplatelet? Is it clopidogrel or aspirin?
So I recently tried to shift my practice to a single antiplatelet using a P2Y12 inhibitor for long term, just based on the host exam trial and other observational studies that showed better efficacy. I don't think the guidelines have changed yet, but we do have compelling evidence to continue with Plavix monotherapy after that.
Okay. Dr. Ride, any final thoughts, from your side? I mean, if the patient came after 5 years with degeneration or stuff, will you say he's now 80? Are we going to go for valve-in-valve at this stage, or should we call you again?
I mean, again, it's all about the patient. If the patient is healthy, if I think he will live long, like if he has more than 10 years, I think it depends. I mean, if the valve fails in 5 years, I mean, maybe we have to explore the other option of surgery. I mean, if he was frail from the beginning, I think I will go with valve-in-valve.
Okay, great. So take it to home.
Sure. So our conclusion, high-risk TAVI with the PCI and document support is a feasible and effective strategy for patients deemed inoperable due to advanced age and comorbidities. Multimodal imaging and multidisciplinary approach, including the presence of a shock team, are key to optimize procedure success and long-term outcomes. Thank you.
Thank you.